on record. Wonderful. Thank you. Thank you all for joining us this morning. This is the first of 3 feedback share-out sessions for the Administrative Burden CCAR and DACODS Modernization Report. Again, thank you for joining us on this chilly Monday morning. My name is Megan Lenz. I use she, her pronouns, and today I will be presenting on feedback that BHA has received from the provider community on the administrative burden, CCAR and DACODS modernization report, and the corresponding BHA responses. I am an experienced designer on BHA's technology team. I have experience working in both the private and the public sector, and now I'm focused on helping to improve behavioral healthcare technology and systems in Colorado. I want to thank all members of our BHA team who has contributed to this body of work and all of the providers who engaged with this report and spent time providing thoughtful feedback. For today's agenda, we are going to start by reviewing the research findings and recommendations that were shared in the report and in the previous share-out sessions in October. Those share-out sessions were recorded and can be found on the project microsite, and my colleague Abigail will be sharing those links within the chat throughout this presentation. We will then be sharing feedback that we received from providers. We received about 50 feedback responses, so we will be using this presentation time to share the most prevalent themes of feedback and the corresponding BHA responses. Full feedback received and the full BHA responses are published on that project microsite, and we encourage you to review that full feedback document. This session is really a continuation of comprehensive engagement for recommendations from the Admin Burden Report to ensure that we are truly holding space for co-creation with providers and people seeking care in Colorado. So for today's agenda, I'll be presenting out for around 30 minutes, and then we'll be holding around 30 minutes for discussion. We might not have all of the necessary people or all of the necessary information to answer all questions during this session, but if necessary, we will follow up with answers as needed. During the 30 minutes of presentation and the 30 minutes of content, please feel free to put questions or commentary in the chat. My colleagues will be reviewing and monitoring the chat during the presentation time. And during discussion, we can review those questions and come to voice. All right, so to begin, we are going to be resharing the top findings and key recommendations from the Admin Burden Report. We would like to start by reiterating BHA's responsibility. It's imperative that BHA address the administrative burden and negative impact on provider-client relationships caused by CCAR DACODS, while also remaining in compliance with federal requirements. The top findings from the report are as follows. The data model for CCAR and DACODS is clinically and culturally out of date. Inflexible data intake into BHA systems results in providers losing out on payment and accurate counts towards contractual requirements. The distinction between CCAR and DACODS perpetuates a siloing of behavioral healthcare and creates high levels of data duplication for the rising population of dual diagnosis clients. Basic usability issues within BHA systems increases the time, effort, and cost required to submit compliant data by providers. Data generated today by CCAR and DACODS provides limited benefit to the state's behavioral health ecosystem at large. And CCAR and DACODS requirements directly and negatively impact how people experience behavioral healthcare in Colorado, especially for intake appointments. These 5 recommendations summarize our findings. So the first is updating the data model through relevant stakeholdering and federal review processes. The second is selecting a data entry system by performing an analysis of existing technology systems, both internal and external, and using recommended design parameters to aid in selecting a new front-facing system. The third, build for episodic reporting through aggregation of encounters and representation of a client in a longitudinal way. The fourth, create data analysis dashboards to facilitate data sharing between BHA and providers, allowing for tracking towards contractual requirements and measures of equity. And the fifth, prioritizing engagements with providers and other key stakeholders to stay true to BHA values of co-creation. All of these key findings and key recommendations can be found within the broader administrative burden report, which is linked on the project microsite. So now we'll be moving into the next section of this presentation, which is focused on community feedback and BHA responses. BHA collected feedback on the broader administrative burden report until October 27th. During the time of collection, we received roughly 50 feedback submissions through the feedback form, through questions from live sessions, and through email. Feedback received was published on the CCAR and DACODS Modernization project site with corresponding BHA responses, and we truly encourage everyone to review that document in its entirety. During the rest of this presentation, I will be focused on highlighting some of the common questions and common themes of feedback that BHA received, as well as BHA responses to those common themes of feedback. So at a high level, there were 4 key themes of feedback that much of the feedback that we received on the report fell under. The first being questions and commentary related to federal compliance and the data model. We received feedback and commentary asking why CCAR and DACODS are required and how the data model might be updated to reduce or address the administrative burden recognized in the report. The second is technology system modernization. Much of the feedback acknowledged that difficulties exist today within the current technology systems and asked how this modernization effort will address technical usability within these technical systems. A third common theme was related to electronic health records or EHRs. Many organizations currently use additional technologies such as EHRs when submitting data to BHA. How is this being considered in the CCAR and DACODS modernization effort? And the fourth common theme that we identified through the feedback was engagement through training and onboarding. We acknowledge that it is difficult to onboard staff to these data instruments and state systems, and a lot of providers responded with asking how this modernization effort may address training or provider engagement. So moving into the first common theme that we received, which was why are CCAR and DACODS required? Many feedback respondents asked why BHA requires CCAR and DACODS submissions, especially as the administrative burden report outlined that they are largely contributing to administrative burden. Feedback also included the heavy administrative burden providers currently face as a result of requiring these data instruments in the form that they take today. CCAR and DACODS are federally mandated data instruments that are required by SAMHSA. BHA is contractually required to submit this data to receive block grant funding from SAMHSA, which allows BHA to administer state-specific programs for mental health and for substance use disorder treatment. In order to maintain block grant funding, BHA must submit data on program participation, utilization of block grant funding, and client-level data to SAMHSA annually. This slide was shared in previous share-out sessions and represents why we unfortunately cannot simply do away with CCAR and DACODS. They stem from reporting requirements from SAMHSA for block grants the BHA passes on to providers. This is similar to how CMS requires reporting from HCPF on Medicaid enrolled providers. Many people have rightfully asked why the BHA why can't the BHA simply pull the necessary data from other sources? Unfortunately, we found that there is enough difference in the types of data required by SAMHSA that there will likely, at least for the near future, always be the need for some data collected from providers by the BHA. Feedback specific to the data model really spoke to the existing data model and the data elements that are required for both CCAR and DACODS. Respondents noted that it is unclear why certain data elements are required for these data instruments, and that certain data elements do not seem relevant for collection during intake appointments with clients and can even cause harm during these intake appointments. Additionally, respondents shared that there are no feedback mechanisms once data is submitted through these data instruments. We know that the data model being used today for CCAR and DACODS is outdated and harmful. There are certain questions that CCAR and DACODS must ask because they are dictated by the federal government and by SAMHSA. Other questions, however, were added previously by OBH because they wanted to collect additional demographic information for state data analysis. So our recommendations include minimizing data elements to only those that BHA can solidly defend, either due to federal requirements or a strong use case for quality and access measures that would be shared back to providers and the general public. BHA plans to engage with stakeholders on this data model, and at the end of this engagement, we should only be left with data entries that we can solidly defend and have explicit purpose for. Moving into the next common theme of feedback related to technology systems. BHA received feedback directly related to the technology systems currently in place for CCAR and DACODS, which are CCAR and TMS respectively. Feedback shared that these technology systems are viewed as outdated, difficult to use, and significantly contribute to administrative burden and the need for additional staff to submit these required data instruments and data submissions. We know that one of the major pain points for CCAR and DACODS is the aging technology. BHA will be evaluating and selecting a new data entry technology system to complement our data lakehouse vendor Snowflake. A successful technology system will address basic usability issues among other key identified capabilities. The evaluation and selection of this new data entry technology system will be chosen with provider input, including a stakeholdering process to ensure that we address provider questions and provider needs in the implementation of a new system. Moving into the next theme of feedback related to additional technologies such as EHRs or electronic health records. Feedback responses posed questions about electronic health records and how technologies like these relate to existing provider workflows and data reporting to BHA. Feedback noted that many providers currently utilize different technology systems, including EHRs, and would benefit from EHR connectivity with data collection requirements for BHA. BHA plans to engage in a broader and more comprehensive EHR research and strategy effort to support BHA's technology infrastructure. BHA acknowledges that to truly design an equitable solution, the technology system must work as well for providers with EHRs as it does for providers without EHRs. BHA plans to take the cost of changes providers and intermediaries must make to align with changing reporting requirements into consideration when working through modernization for CCAR and DACODS. Another theme that we received feedback for was engagement and training specific to some of these technology systems in the current landscape. Feedback respondents shared that product adoption and system training is often difficult. Errors in data submission and resolution of these errors is often very time consuming and can add to the already heavy administrative burden that many providers feel when they are submitting required reports through the existing technology systems and the existing data instruments. BHA needs to improve the onboarding, training, and user experience for providers. This includes rewriting training materials with a trauma-informed lens, selecting a new technology system that has improved usability, among other efforts. These improvements to training and onboarding will be co-designed with providers to ensure that we are providing clear and targeted communications on our data reporting processes. As previously shared in the earlier sessions back in October, the success of this modernization project hinges on accurate, transparent communication, engagement, and training opportunities with providers and people seeking care in Colorado. We must look beyond a technical solution and into the principles of co-design to continue to move this body of work forward. This includes engaging with the Behavioral Health Administration Advisory Council, further understanding the impact and opportunities of behavioral health administrative service organizations or BASOs, engaging in cross-agency collaboration, keeping providers informed of project activities through proactive communications, such as sessions like this and updating the project microsite, and engaging with the public regarding BHA's data and privacy policies, among other things. Feedback responses also asked questions about the definition of episodes of care and the need for this definition to be truly well thought out to ensure that the complicated concept works well for providers and for people seeking care in Colorado. Today, when the BHA analyzes CCAR and DACODS data, it's hard to understand an individual's holistic care journey and what impact behavioral health services have had on their lives. CCAR and DACODS are just moments in time. They're captured at someone's admission or someone's discharge to a particular service, rather than providing that whole person health picture. One way recommendations in this report begin to address these concerns is by defining what an episode of care might look like in a new BHA reporting ecosystem. This means linking together different service level reports inclusive of CCAR, DACOs, and 837 encounters for an individual into a holistic data story of their past treatments so that providers can get that more whole person picture. The episodes of care model was explored and validated by past modernization work. These refreshed recommendations will set a foundation for a future where we can explore additional care coordination possibilities for both behavioral health and broader state services. BHA plans to work closely with providers and people seeking care to co-create this definition so that it will work across different services and settings. Visualized here, we believe that by moving from encounters to episodes of care, we could provide real benefit back to both providers and clients. This effort will, of course, require heavy work with people with lived experience in order to understand appropriate levels and methods for gathering consent. Feedback responses also asked really relevant questions related to the timing of an implementation of a new data model and adoption of a new technology system. Respondents were interested in timelines and noted that mandated changes can require varying amounts of work on the provider technology side, and that must be kept in mind for these changes and updates to the current landscape. We want to express to providers that we will not be requiring any changes to CCAR DACODES entry for at least 1 year after our new specifications are released in order to be respectful of providers' timelines as they update their systems. The data model timeline involves updating the data model for CCAR and DACODES through relevant stakeholdering and federal review processes. The technology system timeline involves performing an analysis of existing internal and external technology systems based on recommended design parameters in order to select a new front-facing data entry system. We purposefully put these two projects on separate tracks to allow for small iterative changes over time. BHA plans to use 2024 to perform pilot testing, to finalize the new data model, and select, build, and launch the data entry technology system, all through co-creation with providers. This timeline is an estimate, and it is truly subject to change, especially because we want to make sure that we are giving providers enough time to provide thoughtful feedback and to implement changes on their own systems. So as for next steps for parts of the administrative burden project, what do we have? So we are hosting 3 feedback share out sessions this week. This was the first of 3 sessions. There are the additional registration links on the project microsite if you would like to attend more of these feedback share out sessions. And we have the full report also posted on that project microsite if you would like to see in detail individual BHA responses to all of the feedback received from the provider community. Following these share out sessions, we will be forming work groups for the data model update as well as the technology systems. If you are interested in participating in these work groups, we invite you to fill out the form that my colleague Abigail will be dropping in the chat. So with that, that concludes the content portion of our presentation today. I'd like to open up the floor for any questions or discussion points that were in chat during this presentation, or if anyone has questions or discussion points that they would like to bring to voice, we can go ahead and do that at this time. And I will stop sharing so that I can see anyone's faces that are on video.
Yeah, and Megan, we don't have any questions in the chat. So I think if folks want to come off mute or to start put questions in the chat, that would be a great place to start.
Thank you, Abigail. And as mentioned, we have a couple of colleagues from BHA. We may not have everybody necessary to answer any questions, but if we do not have the answers to questions, we will absolutely follow up on an individual basis.
I've got a question. This is Nicole Gonzalez with North Range Behavioral Health. At any point, do you see these 2 forms being consolidated into one?
When you're speaking of the 2 forms, the CCAR and DACODS forms?
Correct.
Yes, so that is a work stream within the data model update. We are trying to do as much consolidation as possible. And I see Abigail came off of or came back on camera, so she may have more context to provide there.
Great, thank you.
Yeah, thanks, Nicole. I do believe that that is part of our plan to consolidate. That was something that was validated through our research and also validated by previous modernization projects. So we'll be able to provide more detail there. And I see Ria came off mute, who is a wonderful data analyst. I'm not sure your exact title, but maybe Ria and Megan can talk a little bit about like the plan for that and also the plan for stakeholdering, which Nicole, if you're interested, definitely sign up for the data model work group via that form that I just shared, because there will be more good details shared via that initiative.
Great, I'll do that.
Thank you. And Ria, did you have any additional things that you'd like to add there?
Just happy to be a third person to say, yes, we are consolidating the 2 into one model.
Are there any other questions or discussion points that anyone would like to raise? Abigail did mention in the chat that we do have 2 more of these sessions this week. I can also include my email in the chat if you'd like to send any questions or discussion points directly to me if you don't feel comfortable coming off of mute.
Hi, I have a question. My name is Laura Dykes. I'm from Colorado Coalition for the Homeless. Thanks for doing all this. What is if you know yet, how are you approaching the EHR kind of technical question? There are so many different systems that people use. And so I'm just wondering, I'm curious about how that's going to work.
Yeah, hi Laura. Thank you for that question. We are still putting together a more comprehensive research and strategy effort around EHRs, but want to be very conscious of what you just mentioned, where there are a lot of different technology systems out there. So we need to approach this strategy in a very equitable way, understanding what the landscape looks like, but again, also focusing on building a technology solution that works for those with EHRs, as well as for those who do not have EHRs. So don't have much more information there yet, but I encourage you to participate in the technology system stakeholdering group. That will definitely be a point of discussion in that stakeholdering group.
Thing. I just sent message one of my staff to join the work groups. I would suggest, I don't know if this might work, but maybe surveys with providers or organizations about what type of EHR they use in creating groups within those people that all have the same EHR, because there could be some leveraging back with the actual company that owns the EHR to be able to work on things.
Yeah. Yeah, thanks for that. I think that is something we actually have already started to do. So through our various research projects over the last year, spanning from everything from admin burden to referrals, we have started to get a better sense of, and I think we know this from engaging with all of you, right? What are the big hitters in Colorado around EHRs? What work groups are already existing? Because there are actually already provider-centric work groups with the EHR. So we want to make sure that we're respecting those efforts and tapping into those efforts before we create anything new. And then Megan, the only other thing I would add is that one of the things that we've, understood over the last year is that as we're building out this new digital infrastructure for BHA, we understand that we have to think about EHR integration across all of our technology projects. So that's kind of how we're approaching that this year, is we're going to have a dedicated effort around EHRs, and then we're going to apply that strategy across different projects like this. So we'll continue to, update y'all in meetings like this, even though it's going to be a slightly kind of different effort, because we know that we need that EHR strategy to really work across our digital infrastructure and not just on like one singular application like CCAR, DACODS, and whatever we're going to call it next. But I think that's a really great question. Thanks for bringing that up.
Abigail, real quick, the difference between the data model work group and the technology system work group, what's the difference between those two?
Go for it, Megan. You got this.
Perfect. So I'll start and then I'll tag Ria in if she has any context that I've missed, but the data model is specific to the data elements that are being collected for both CCAR and DACODS, understanding what those data elements are, what is federally required by SAMHSA, and what additional data elements, if any, would provide benefit to the behavioral health system in Colorado and for providers. So that is the data model specific to the data elements. The technology system is more surrounding the front-facing technology system that will be replacing CCAR and TMS respectively for CCAR and DACODS. So where providers will be able to go to physically submit the data that will then go to BHA. And I'll pause there, and if any of my colleagues have additional information or additional context they'd like to provide, I'll let them jump in now.
That's great information. Thank you, Megan.
Thank you.
Yeah, Yeah, Megan, I think that was perfect. Said another way, send us your data nerds to the data model and send us your technology nerds to the technology work group, or the like, EHR or whoever's kind of like managing the guts of your technology system.
We still have about 30 minutes for any additional discussion or questions that anyone may have. I really appreciate all of the questions surrounding the stakeholdering groups. As mentioned, that is a large effort for the next steps of this phase of the administrative burden project. So I'll just do another plug for us to drop the link in the chat, but we really do encourage everyone to consider if they would like to participate in one or both stakeholdering groups. But yes, please send us all of the very smart people that we can work with to co-create better technology systems in Colorado.
Yeah, and I also want to say that just because we're having these work groups, I want folks to understand that we're also doing pilots and testing and like making progress at the same time. So it's not like one of those government projects where we have a work group and we're like stalling out because we're having these sessions for however many months. Like we're really trying to change these work groups to be a place where we're really taking active, like in-build work to our providers who are our users, in this particular stance. So if you join these work groups, that's really going to be, hey, what do you think about this? We're bringing this to you live. We're testing something together. So very, very like tactile and active versus something more discussion based where we're like building up to a decision, if that helps you to make a decision about whether or not to participate.
This is Zach from Crossroads. I was debating about asking this now versus like more of a work group question. But in terms of like the data model and the mapping, do we have flexibility in that, like, let's just say, for example, for modality, that it's captured in a certain way, but then it's remapped for what SAMHSA is looking for in terms of their categories? Do we have flexibility like that, especially as our modalities and things evolve in our system?
Ria, do you have initial thoughts for that?
I do, but I would like to ask a clarifying question to make sure I'm understanding the question. When you say modalities, do you mean like the front-facing terminology that's used? And I'm wondering if you could maybe give me an example as opposed to like the tech, so the terminology around the data elements or the technology itself. What are you referring to?
We're like, let's use DACODS as an example. When we're submitting things, we have to select, are they in detox, are they in stirred, and like the OP versus IOP. There's obviously some things that might kind of be in a weird gray space, like for example, enhanced outpatient. I mean, technically you could slot under the outpatient selection, but is it truly traditional outpatient? And so I think the flexibility where providers, when they're inputting data, it's very intuitive, and there might be extra information that the state might like or that we as a system might like that SAMHSA is not going to care about. And so the ability to either, I know some EHRs can rekey values, but I would imagine that at least going to you guys, we would want the raw and then the flexibility to remap for SAMHSA.
And Zach, I'll jump in here real quick. Currently, we do translate those values to SAMHSA, so we do have that kind of flexibility. SAMHSA has some pretty rigid modality standards, so we sit there and do our best job of mapping what we collect into that. So yes, we would have flexibility there for sure.
Okay, cool.
Yeah. Thanks, Zach. This is a great question. I'll point you to a specific section of the report, and Ria and everybody keep me honest on this. But like one of the things that we saw from like an equity standpoint is that a lot of the language that SAMHSA still uses is outdated, right? In terms of gender and sexuality. And we wrote about that a lot in the report. So we know that mapping is something that we will have to do in order to reach those equitable goals in terms of the language presented to providers and clients in some cases. So mapping flexibility definitely on the table. I think, again, that's probably where the tech system work group and the data model work group will come together and maybe have some sessions where we'll talk about how flexible we can be and like what our guidance might be for EHRs to help to facilitate that mapping. So I think that is definitely on the table and something that we will definitely get into the guts with in those sessions, even more so than like the gender and sexuality options.
Awesome, thanks.
Ria, did I get any of that wrong, Megan? Okay.
Are there any other questions or things that people would like to bring to voice? We do have this room open for another 20 minutes, but if there are no questions, people may start to trickle out. I can input my email address again within the chat to welcome any additional comments or questions. The BHA team will continue to stay on the line, but if there are no questions from the provider side, please just feel free to take any time back. And thank you, Abigail. We got 2 emails in the chat. Thank you all for attending today. We really appreciate your engagement.
All right, Megan, I think we're good to close it down.
Perfect. I'll stop the recording and end the meeting. Thank you all.